Hello, everybody. Thank you for IHRS for giving me the opportunity to present this case of an implantable device troubleshooting. This is an 81-year-old male with non-ischemic cardiomyopathy, severe LV dysfunction, who had a secondary prevention single-chamber ICD, was on amiodarone and beta blockers for multiple appropriate and inappropriate shocks, and came with worsening left ventricular failure. He had 12% PVCs of varying morphologies on a 12-lead Holter. The RV pacing threshold from the existing lead was 3 volts at 1 milliseconds. The device was at ERI due to the multiple shocks, and he had 78% RV pacing at a lower rate of 60 beats per minute. We upgraded it to a conventional biventricular pacing device and changed the RV lead to a mid-septal location, had good parameters from all the leads. The post-BIV ECG doesn't look bad. 5 minutes later, he had recurring episodes of tachycardia at 115 beats per minute with a 1:1 VA association and negative P waves in the inferior leads. You can also see that it's a pure right ventricular pacing morphology, not a biventricular pacing morphology. So what is happening? Is this a pacemaker-mediated tachycardia or a low atrial arrhythmia? Why only RV pacing? Why did this occur? And what is the solution? Let's look at the device parameters. The key parameters are underlined in blue. The upper rate is 130 beats per minute or 460 milliseconds. Biventricular pacing 0 with a sensed AV delay of 120 milliseconds. Left ventricular sensing is on, which is available in Biotronic and Boston devices. PVAR is 250 milliseconds, which is extended to 400 milliseconds after every beat that is diagnosed as a PVC. And LV T-wave protection is on with a maximum trigger rate of 130 beats per minute or 460 milliseconds. Just to explain this, LV T-wave protection means that after every sensed or paced LV event, the next left ventricular impulse will be delivered in the LV only after completion of the maximum trigger rate in the LV channel. This does not prevent an impulse being delivered in the RV channel. This is designed to prevent RNT pacing on top of a left ventricular PVC. So let's look at the electrogram of one of the episodes. Here the electrogram zoomed in. This electrogram shows a self-terminating episode. We can see that the episode is started by, so let's start where the problem starts. Here's a PVC, LV sense before RV sense. Here's a PVC, LV sense before RV sense, conducted to A, falls in the PVAR. Here's a PVC, conducted to the A, falls in the PVAR, therefore not tracked. Here's a PVC. The PVC is Wenckebaching now. It's conducted to the A. It is not diagnosed as a PVC. It doesn't fall in the PVAR, and it starts a PMT where there is only right ventricular pacing in the PMT. And the sequence continues. The right ventricular pacing conducts to the VA, also goes to the LV sense. That is tracked. Right ventricular pacing goes to the VA, also goes to the LV sense, conducted to the LV. So the sequence goes on. There is VA Wenckebach going on. And at this point, a right ventricular PVC comes, and this is not conducted to the A, and that terminates the PMT. So this is a PMT. Now, why only RV pacing? Let's look at this. The PVC, LV sense preceding RV sense, goes to the A, not diagnosed as a PVC, PVAR not extended. If it had to be paced, tracked into the LV, it would have to be tracked at 430 milliseconds because the sensed AV delay is 120 milliseconds. Of note, the AV Wenckebach feature does not apply to the LV. It applies only to the RV pacing. So it was not tracked to the LV, but it was tracked to the RV as soon as the RV upper rate interval is over at 460 milliseconds. And that goes back to the A, and it goes on. Cannot satisfy the LV upper rate interval. So the A is not tracked to the LV, but the A is tracked to the RV. And finally, the RV PVC here terminates it. So this is why there is only RV pace during PMT. If we turn off LV T-wave protection, we'll have PMT, but it's biventricular pacing, but we still have PMT. So why did the PMT occur? So here are the beats which are diagnosed as PVCs, and the A sense falls in the PVAR. But here is a beat which is a PVC, LV sense preceding RV sense. the PVRP extension did not occur because this PVC was not diagnosed as a PVC, and this is why the PMT occurred. So the PMT occurred because this PVC was not diagnosed as a PVC. So let's examine the diagnostic criteria for a PVC. The first diagnostic criteria for a PVC is an AVVA sequence, which is common for all manufacturers. Biotronic has an additional diagnostic criterion for a PVC, which is an AVS sequence with an AV interval of more than 350 milliseconds, which is specifically designed to diagnose a PVC in this particular sequence. So let's see what's happening here. AVVA sequence diagnosed as a PVC. AVA sequence diagnosed as a PVC because the AV interval here, the A to V interval here is more than 350 milliseconds. The A to V interval here is 460 milliseconds. But here is an AVA interval where the AV interval is less than 350 milliseconds. Therefore, this diagnostic criterion has also failed. So both the criteria have failed and started a PVC. So how do you prevent PVMT initiated by ventricular couplets of P by your NSVT with a VA conduction? The key is to diagnose each beat as a PVC. How do you do that? One way to do that is to think of PVC not in terms of AV relationship, but also in terms of VV relationship in devices with LV sensing. This is what I mean. LV sensing preceding RV sensing, I guess by a predefined maximum interval to reject unphysiological LV to RV delay. In this particular patient, the LV sense to RV sense delay was 101 milliseconds, the maximum being 120 milliseconds, could diagnose a PVC. This would not be reliable under conditions of late RV sensing, as in right bundle branch block. This also would not be reliable in case of an LV septal PVC, which is diagnosed earlier by the RV lead than a posterolateral LV vein lead. It would make sense to incorporate such a PVC definition into the device and to give the operator to turn this option of PVC definition on or off after confirming that the sinus beats bear an RV sense to LV sense pattern. So how would this modified diagnostic criteria for PVC work in this patient? So LV sense precedes RV sense. All of these would have been diagnosed as a PVC, including this last one, where the AV interval is less than 350 milliseconds and therefore not picked up by this second diagnostic criteria. So this would have been diagnosed as a PVC. The VA would have been extended so that this A sense would have fallen in the PVR and not tracked into the RV and not started a PMT. Would have prevented this RV pace because the RV pace would then occur only at the RV lower rate interval of 1000 milliseconds. Would have correctly diagnosed this PVC and prevented this PMT. This is another PVC PMT sequence from the same patient. AVA sequence with an AV delay of less than 350 milliseconds starting a PMT, but with an LV sense to RV sense sequence. Would have correctly diagnosed and prevented this one also. AVA sequence with an AV interval of less than 350 milliseconds, but an LV sense to RV sense sequence starting the PVC. Would have correctly diagnosed and prevented this also. AVA sequence, AV delay less than 350 milliseconds, but LV sense to RV sense sequence. So among the 10 recorded episodes of PMT in this patient, all triggered by 2 or more consecutive PVCs from the LV, a novel PVC definition of LV sensing preceding RV sensing would have correctly reclassified the initiating RV sense as a PVC in 10 out of 10 instances and would have prevented a PMT in all the 10 instances. So to conclude, wrong annotation of a PVC as an RV sense predisposes to PVC-mediated PMT if the PVC conducts retrogradely, and this can happen commonly in presence of a couplet or an NSVT. The current algorithms are inadequate to diagnose this. In LV sensing-enabled devices, among patients with verified RV sense to LV sense sequence during sinus rhythm, most patients are expected to have this. Addition of a novel diagnostic criteria of a PVC as an LV sense followed by an RV sense is likely to have a high specificity to diagnose a sequence of 2 or more PVCs arising from the LV. Of course, this concept needs verification in a large number of stored electrograms. Thank you.
Good evening, everyone. Myself, Dr. Anil Kumar, Senior Resident from Sri Chitra Tirunal Institute of Medical Sciences and Technology, Kerala. Today, I'm going to present a case of leptobundle area pacing using PVC template as a marker of leptobundle capture. So, as we all know, physiological pacing is becoming popular over last decade. Uh, Physiological pacing has its own advantage of being uh, directly activating the conduction system of the heart, resulting in synchronous activation of the ventricles. So initially, spinal pacing has become emerged as an ideal form of physiological pacing, but it has its own limitations. Of one of them being it's technically difficult, and there are issues with the lead stability and high lead threshold and significant early battery depletion. So all this led to an alternative form of physiological pacing being left-bundle area pacing, which has its own advantages of being left-bundle capture can be done at low threshold, and there is a significant stability of left-bundle lead and a pacing correction of the distal conduction system disease. So uh, while performing left-bundle pacing, there are many criteria have been introduced for confirmation of capture of left bundle area. So, but none of the proposed criteria has been not been validated. So today I am going to present a case of left bundle area pacing using PVC template, which can be used as a marker of left bundle capture. So, so I'm going to show a case of a 60-year-old lady. She came to us with history of pre-syncope and EC fatigability, and an evaluation. Her ECG documented to have a complete heart block with a narrow QRS escape. So this is her baseline ECG, which is showing a complete heart block with narrow QRS escape with the atrial rate of around 100 beats per minute and ventricular rate of around 40 beats per minute. As she is having symptomatic T-syncope, and easy fatigability, she was planned for pacemaker implantation. This is her baseline intervals, which showed QRS duration of around 100 milliseconds with the QT interval of around 539 milliseconds with HV interval of around 45 milliseconds. So it's stroke suprahuman conduction system disease. So this is what I was talking about. While doing left bundle area pacing, we noted there's a PVC template which is of RBB morphology with QRS duration of around 120 milliseconds. So, which is has been proposed as one of the marker for left bundle capture. So, when we noticed this PVC template, we stopped for further rotation of lead while fixing lead, so, and we able to demonstrate left bundle capture by demonstration of left bundle potential, which is high frequency sharp spike seen 20 milliseconds preceding local ventricular electrogram. And further, we confirmed left bundle capture by demonstration of change in QRS morphology from non-selective to selective. So selective, which is preceded by QRS morphology being preceded by uh, isoelectric line. And here we can see there is change in QRS morphology from QRBB pattern to RBB. And further, this we have demonstrated non-selective left bundle capture at low output using unipolar lead capture. And similar thing has been able to be able to demonstrate using bipolar capture from non-selective to selective capture at low output. So further, we confirmed the position of the lead in RAW view. This is RA lead and left bundle lead in RAW view. And we also able to confirm its lead position in LAO 30 view. So finally, we confirm that left bundle capture and finally successful left bundle area pacing was done by demonstration of RBB pattern in V1 with QRS duration of around 100 milliseconds. And we are able to demonstrate left bundle potential and the transition QRS morphology from non-selective to selective capture has been demonstrated using bipolar capture and both the unipolar and bipolar capture, and peak left ventricle activation time measured in lead V5 and V6 being 54 milliseconds at low and high output. So this is our final ECG, which is showing QRBP with the QRS duration of 100 milliseconds, and she is doing well on follow-up. So while fixing the left bundle lead, when to stop further rotations, one of the criteria being left ventricular activation time should be short, that's less than 80 milliseconds at both high and low outputs, and others being unipolar pacing impedance should be more than 450 ohms, and we should be able to demonstrate left bundle potential. And when we notice PVC of right bundle branch pattern, we need to stop further rotations. And one other complication being while any pacemaker implantation, while fixing the lead, is ring perforation. While doing left bundle area pacing, we need to suspect perforation when impedance falls more than 200 ohms and when unipolar impedance is less than 400 ohms, and when there is increase in capture threshold and decreased sensitive R wave amplitude, and when there is a loss of injury current in unipolar electrode. So coming to the template bit, the template bits are usually generated from the Purkinje fibers due to the mechanical trauma induced by the pacing lead as it moves rapidly into the left bundle area. And a PVC with RBB delay morphology with QRS duration of less than 130 milliseconds will be generated as the lead reaching the left bundle area. But in the presence of scar, this rapid rotation may not be possible. In that situation, we may not get PVC. And but in the presence of scar, it may be difficult to screw the fluid further in, and it may result in repeated attempts, leading to increased risk of myocardial injury. And the template beam will be useful by avoiding the further rotations once the template twists are observed, and it will minimize the chance of perforation. In a study by Ponusam, he found that template beat with right bundle branch delay pattern was observed in around 58% of patients, and it was told that this can be considered as a marker of left bundle area capture. And left bundle area pacing using template bit as a marker of left bundle capture will be associated with less fluoroscopic time and noted to have narrow QRS duration and short peak left ventricular activation time. And template bit guided lead deployment would confer minimal myocardial injury by minimizing the further rotation, and also it will help in avoiding septal perforation during lead deployment. So in conclusion, left bundle area pacing is emerging as an alternative to cisbundle pacing, and template bit guided lead placement would help in safe positioning of the lead in the LVD area, avoiding septal perforation and minimizing the myocardial damage. Thank you.
Ajit, can I ask you a question?
Yes, sir.
So in the PMT that happened, it's very nicely demonstrated how the atrial complex was used for a PMT. Why is it that when the PMT happens, the LV doesn't pace?
So the LV doesn't pace because, like I said in the presentation, normally when an atrial impulse falls very rapidly, the device would Venki buck and pace at a longer AV delay than the programmed sensed AV delay. Here, the sensed AV delay is 120. Now, Biotronic has this quirky feature that the AV Venki buck feature during rapid atrial rates applies only to the RV and not to the LV. So when the A happened at a rapid rate, if it had to be paced with a sense AV delay of 120, it would have been faster than the LV upper rate interval. And the AV Wenckebach feature is not applied to the LV. It is applied only to the RV.
Right. Because I've seen a few PMTs and the BIV was still happening. I'm talking of one patient who had a PMT with a
yes, it would happen so long as it doesn't violate the LV upper rate interval.
Right.
It has a separate LV upper rate interval and a separate RV upper rate interval. The difference between the two is the AV Wenckebach feature is applied to the RV upper rate interval, but it is not applied to the LV upper rate interval. And LV, either it tracks at sensed AV delay or it doesn't track.
Right. And on the programming, you could find that it was RV pace, not BIV pace.
Yes, absolutely. We have the patient was in recurrent PMT, so we just kept the programmer on, and we were able to record the 12 lead ECG as well as get the programmer electrograms at the same time.
Right. Now, Dr. Anil Kumar, your presentation is nice, but the fact remains that this marker may be specific, but the sensitivity is extremely low. So
Yes,
you
sir.
can't recommend that you wait for the PVC to come. So with each rotation, you have to pace and find out what's happening. You can't just say that wait for the PVC to come, keeps rotating till a PVC comes. PVC sensitivity is extremely low. So if you do 100 implants, 7 or 8 will have PVCs, others will be silent. So each rotation has to be followed with the pacing. You cannot just say that PVC comes only, then you stop rotation. So it is, if you see PVC, good, you can stop and check. But if you don't see a PVC, you just cannot keep rotating.
Yes, sir. Actually,
It's very, very low.
yes, sir.
Sensitivity of this phenomenon is very low. Actually, more sensitive is when you put in the lead and you see PVCs. That is very common when you put it on the septum. And then if you see a notched PVC, that is the time to progress. Instead of pacing, you could just straight away go in progress. If you don't see a notched in V1, a Q notched in V1, if you don't see with the initial PVC. Initial PVCs are much more common than once you have in the muscle and now entering into the LV septum. Those PVCs are rare. So the sensitivity of this test is extremely low.
Yes, sir.
Yeah, Dr. Sachin, I had one query. I commend you on the presentation. It was excellent and elegantly studied. My question was that if these patients have a lot of PVCs, what is the programming you do for them? Do you do a VPC?
Well, the
PVC trigger on,
LV protection, the LV T-wave trigger must be off. In any biotronic or LV T-wave protection should be off in any biotronic CRT in a patient with a PVC. As simple as that. I think there was a little bit of error there, but that led to a lot of learning. I mean, some things I learned by making these small errors. That was my oversight. When I noticed that the patient had so many oversights, PVCs, I should have left the LV T-wave protection off. But yes, let us learn all this stuff.
Right. No, my query is like for in general, if you're not using a biotronic thing, and you have
if you're not using
PVC
a biotronic thing, then you have to put it on. Well, if you don't have a biotronic thing, this issue doesn't occur. The issue occurs because, see, there are two things. No device other than biotronic has a safety feature of preventing PMT in a couplet with VA conduction. Because that feature of AVS interval with AV interval more than 350 milliseconds is a good thing. The Biotronic is the only company which has that second additional feature to diagnose a PMT. So with a non-Biotronic device, there's nothing to do. If he has a couplet with a VA conduction, he will have a PMT. The Biotronic device, if he has a couplet with a, so that device, that thing is on by default. We cannot change the PVC definition. So there is nothing to do with the PVC definition. PVC definitions cannot be changed. And a non-biotronic device, it has only one PVC definition, AVVA sequence. So there is nothing to do in the programming in that part.
Correct. Right. Agree. Yeah. Elegant case, very nicely studied. I think, Dr. Balbi, you have any questions or we can progress further?
Yeah, I'm fine with it.
Yeah, I think we'll go on with the next two presentations.
Good evening, everyone. Myself, Dr. Anil Kumar, Senior Resident from Stitch.
Hello everyone. A warm welcome to everyone to the Digital IHRS 2021. At the outset, I would like to express my sincere thanks for having been given this opportunity to present my case abstract in this prestigious session. As we all know, asynchronous spacing is the expected response after application of a magnet to interrogate a pacemaker. An unanticipated response, as illustrated in our case, initially led to a diagnostic dilemma. However, a systematic approach with careful analysis of electrograms allowed us to clarify the complex electrophysiological mechanisms involved. My case is of an asymptomatic 48-year-old gentleman who presented to our device clinic for a routine interrogation of his pacemaker. He had undergone a coronary artery bypass grafting and mitral valve replacement 5 years ago. Unfortunately, he developed an infective endocarditis of his aortic valve within a year, which necessitated aortic valve replacement. This was further complicated by a post-operative intermittent high-grade atrioventricular block, for which we implanted a Medtronic Advisor DRMRI, dual-chamber transvenous pacemaker with right atrial and right ventricular apical leads. Previous device interrogations had not detected any sensing or pacing abnormalities. The pacemaker was programmed to a DDD-R mode with a lower rate of 70 beats per minute, upper tracking rate of 120 beats per minute, upper sensor rate of 120 beats per minute, sensed and paced David delay of 150 and 180 milliseconds, respectively. As per our protocol, we performed a 12-lead electrocardiogram at baseline, followed by magnet application. The ongoing ECG shows a predominantly wide QRS rhythm at a rate of 70 beats per minute, interspersed with short-coupled, relatively narrow QRS complexes, although they are also 140 milliseconds in duration, of a different morphology, which brings us to the first question. What is this beat? Is it a ventricular premature beat? Is it a conducted APC? Is it a junction ectopy? Or is it a conducted atrial pace beat? The answer to which we would hopefully reach by the end of this presentation. Analysis of the baseline ECG along with the magnified rhythm strip is compatible with the sequential AV pacing at a lower rate of 70 beats per minute. Atrial and ventricular pacing spikes are associated with the consistent capture, albeit with a low amplitude pace periods. The left bundle branch block morphology of the wide QRS rhythm with its late recorded transition in left superior axis is also compatible with the right ventricular apical pace. The narrow QRS complexes are followed by a delay in resumption of sequential AV pacing. This suggests that they are adequately sensed by the ventricular lead with an appropriate reset of the pacemaker timing cycle. Now, when the magnet was applied, there was an interesting observation which we noted. There was a transition from a wide QRS rhythm at 70 beats per minute to a relatively narrow QRS rhythm at a slightly faster rate of 85 beats per minute. Now comes our second question. What is the most likely mechanism for the transition from the wide to the relatively narrow QRS rhythm pursuant to the magnet application? A thorough scrutiny of the magnet response reveals that the first four wide QRS beats, the fourth beat being denoted by the arrow at which time the magnet is applied, it occurs at lower rate of 70 beats per minute and are preceded by tiny spikes, pacing spikes. This is consistent with DDD pacing, but the low amplitude P waves are not easily discernible. This is followed by an acceleration of the paced QRS complexes to 85 beats per minute. This is in fact the expected magnet rate response for a normally functioning newer generation Medtronic pacemaker. The first also observed was that the first narrower QRS complex is coupled to the last paced QRS complex at a shorter cycle length of 600 milliseconds, that is 100 beats per minute. Subsequently, the rate of the narrow QRS complex is also 85 beats per minute. While a ventricular origin of this narrow QRS complex is still possible, the exact rate of 85 beats per minute alludes to the possibility of a conducted rhythm. Now, we thought we would see what the intrinsic rhythm was, and also to establish that this magnet response was not a one-time thing. We reproduced the same response from the wide to the narrow QRS rhythm with another magnet application. On the upper left-hand panel shows a slower intrinsic rhythm with shorter coupled and a longer coupled RR intervals. There is suggestion of low amplitude P waves in front of every QRS, in front of preceding some of the QRSs. However, it is difficult to confidently annotate a P wave in front of every QRS. We can still infer that at least the shorter coupled RR intervals may be associated with the sinus or atrial capture with long wave conduction, better discernible in lead AVF. These views. This relatively narrow QRS complexes noted during the magnet response also exactly replicated with the 12 by 12 ECG match to the intrinsic QRS morphology. Magnified lower panel shows tiny atrial spikes at 85 beats per minute, but during magnet response they precede the relatively narrow QRS complexes. The second black arrow is coupled to the first black arrow at a relatively shorter coupled interval of 85 beats per minute and represents the onset of TO magnet response. Thus, it came to our mind the most likely inference is that there is 1:1 AV conduction, a very prolonged AV interval during magnet response, and the captured P waves are in fact masked by the conducted QRS complexes. So, how do we prove that? We first found out what the device saw during the magnet application. This is the device region script during magnet application. The red arrows indicate the application removal of the magnet respectively. On the region strips, you can also see the magnet application being started at the point where there is DO over 85 beats per minute and test ended. The conducted QRS complexes are not sensed during asynchronous DO pacing. The ventricular pacing function non-capture occurs at the end of each conducted QRS. When the magnet test ends, last atrial phase beat at a rate of 85 beats per minute conducts with a very long PR interval as became a sensed QRS, annotated by the device as VS. Subsequently, there is the assumption of PDD pacing at 70 beats per minute, again with sequential atrial ventricular capture. We also found that atrial pacing in AI mode at progressively faster rates from 40 to 90 confirmed decremental AV conduction as seen by the slope of these arrows with progressive prolongation of the PR interval and eventually early onset of atrioventricular ventricular at rates above 100 beats per minute. You can see the ventricular happening with progressive increase in slope of the PR interval conduction. So much so that at a rate of AI pacing of 120 beats per minute, there was indeed a 2:1 conduction. So this brings us to our initial question. What were those narrow QRS beats? The ladder diagram is furnished here to explicate the proposed electrophysiological mechanisms involved. During sequential AV pacing, there is likely antigrade and retrograde concealed conduction to the AV conduction system. Decremental retrograde concealed conduction with a retrograde block for every fourth phased ventricular beat is being postulated. This is followed by this allows preceding atrial phased beat to conduct to the ventricle with a very prolonged AV beat, and this is subsequently followed by the assumption of sequential AV pacing again with both antigrade and retrograde concealed conduction in the AV conduction system. So normally a ventricular phenomena is manifested by a dropped ventricular element. Here in this case, the retrograde concealed decremental conduction with the ventricular is unmasked by a conducted element. That was interesting. Now coming to the magnet application, why the transition from a long wide QRS to a short narrow QRS? Application of the magnet not only changes the pacing mode from synchronous DD to asynchronous DOO, but also accelerates the rate of AV pacing from 70 to 85 beats per minute. This creates a long short cycle both in the atrium and the ventricle, which is expected to be reflected in the conduction system, disease conduction system as well. This long short sequence interrupts concealed conduction from the ventricle, but allows long AV conduction without Venki back to manifest itself. The captured P waves are masked by the conducted QRS complexes. Upon close inspection, you can actually see, as was seen on the device EGM strip, that there was a ventricular pacing spike towards the end of each conducted QRS with functional non-capture, consistent with the expected magnetic response of BO. The interval between the last captured ventricular beat, that is the third beat, and the first conducted QRS, as we saw previously also, it was 600 milliseconds, 100 beats per minute. This is not coincidental, but this is an indicator of the possibility of intrinsic AV conduction occurring. Hence, a diseased conduction system, as in our patient, may harbor concealed or decremental conduction and is quite susceptible to long short sequences. This can yield interesting interactions best between conducted and paced rhythm, even at relatively slower pacing rates. However, an understanding of the systematic approach of device tracing in ECG, familiarity with magnetic responses, and appreciation of complex CP mechanisms can help in understanding and deciphering the underlying electrophysiological mechanisms in it. And finally, the answer to your question: what was that beat? Indeed, it was done in a digital beat. With this, and then presentation, thank you.
Good morning, respected judges. I am presenting unusual ECG finding in a patient who came for a routine pacemaker follow-up. My case is a 65-year-old gentleman who underwent a dual chamber pacemaker implant for symptomatic complete heart block. Now he comes for a routine pacemaker checkup. He was asymptomatic otherwise. He had Abbott Endurity core device. The AV delay was 150 milliseconds of sensed and 200 milliseconds of paced AV delay. With a VIP of 100 milliseconds, the auto capture was on. When the pacemaker patient, after getting ECG, he went to the device clinic, but the Abbott technical staff picked up that there is some issue with the pacemaker, and he came to me saying that there might be some issue, and because it appears that the dual chamber pacemaker may be functioning something like a VVI pacemaker. We had another tracing, which also looked like that as if there is a single pacing spike irrespective of the P wave. In between, there are two pacing spikes. And the two pacing spikes, what look like could be A and V pacing spike, or it could be something else, because if we look at here, that there are two pacing spike, but the initial pacing spike is giving rise to a QRS complex. And secondly, it is unusual to have this short AV interval, which is almost 80 to 100 milliseconds. So we thought that at this time, the two possibilities were when we have very closely placed two pacing spike and the first pacing spike producing a QRS complex, we always have to think about a RA lead dislodging into RV, or there is a lead reversal in the header. The second pacing spike could be because of safety pacing. But as there was a magnet ECG available, we found that with magnet, there was a consistent A and V pacing with good capture of the atrium and ventricle. So both these possibilities seemed unusual or less likely. When you look back in the initial ECG, we found that although it appears that there is a pacing spike looking like a VVI pacing, but almost all the beats except these two beats, almost all the beats has a P, and immediately after a P, there is a pacing spike. So the pacemaker was possibly functioning in a dual chamber mode, but the AV delay was very short, except these three beats. We'll be discussing in detail what are those beats could be possible. So our usual differential diagnosis was maybe there was some atrial lead sensing issue, but had it been atrial over sensing, we thought that there will be erratic ventricular pacing had it been there atrial over sensing. So this was not the case because almost there was a consistent V pacing after a P wave. Secondly, there was no atrial under sensing as well. In that case, we could have expected unnecessary atrial pacing spike, which was again not the case. So these two possibilities were like early depletion or automatic mode switch. The pacemaker can function like V in VVI, but as we know that most likely, although we're not sure without the marker channel, but we can see that it was almost like A sense V pace happening with a very short AV delay. So we were left out with these two possibilities, that either some automated pacemaker algorithm is going on, which can be normally functioning, or there can be some abnormality in the automated pacemaker algorithm. Which we are thinking all this, we found that the only pacemaker algorithm which functions at a very short AV delay of 25 milliseconds is the auto capture threshold search. So when there is auto capture threshold search, the device goes into a very short AV delay mode to avoid the intrinsic conduction. So before I go into my case, I'll just briefly discuss about how auto capture functions. The auto capture principle is based on pacemaker's ability to recognize the evoked response. What is the evoked response? The evoked response is the signal resulting from the electrical activation of the myocardium by the pacemaker stimulus. And the auto capture has to function with this detection of the evoked response without being misled by the polarization signal or the polarization artifact. The polarization artifact is due to ion accumulation at the electrode tissue interface. The magnitude of the polarization signal at the pacing site is generally constant, irrespective of the myocardial capture. This is in contrast to the evoked response, which depends on the true myocardial capture. So whenever we switch on in the beginning, the auto capture feature is switched on, it always assesses a evoked response to polarization signal ratio. And when this ratio is favorable, the device asks that it is recommended to program auto capture, and then only we should program auto capture function. On follow-up, when does the auto capture threshold search happens? Like in this case, we feel that there's auto capture threshold search going on. Either it happens every 8 to 24 hours, which can be preset, or if there is a pacemaker detects loss of capture in 2 consecutive beats and there is a backup pulse, then it can start a auto capture threshold search, thinking that there might be some threshold issue. The third scenario when it can happen is when a patient leaves a device clinic after the device checkup or wand removal or magnet removal. This auto capture threshold search happens once again. So in dual chamber pacemaker, it happens with a 25 milliseconds AV delay in sensed, if it is a sensed P, or 50 milliseconds when it is a paced P. So how it works is like if there is any there is a rise in the threshold, and if there is a loss of capture, immediately the high voltage backup pulse come, which is around 5 volts amplitude, and after that the pulse amplitude is increased. So after the pulse amplitude increases and there is a true or accurate capture, the device starts this auto capture threshold testing. How it does? It comes down by 0.25 millivolt. Like in this case, let's say the capture was found at 1.25. Now it will start auto capture threshold testing. It will come down by 0.25. It paces at 1 volt, but there was no capture. So no significant evoked response was detected. Hence, there is a backup pulse. This happens twice. So it goes up by 0.125 125 volt. And let's say that also there is no capture. So it gives a backup pulse. After that, it again increases by 0.125. And let's assume that at 1.25, there is a appropriate capture. So after 2 appropriate capture, the device declares that this is my auto capture threshold. So once this auto capture threshold is decided and declared, since after that, then onwards, there will be a addition of 0.2 volt, that is the pacemaker, this particular pacemaker will pace at, let's say, 1.5 now on with a set AV delay. Before this, till the auto capture threshold goes on, until the declaration of the auto capture threshold, this AV delay is at 25 milliseconds for a sensed AV delay. But after the declaration, when this 0.25 is added, 0.25 volt is added, the auto capture will start with a normal pacemaker functioning with a set AV delay. So coming to our own case, what we feel that these 3 beats were due to auto capture threshold testing, and this third beat in the upper panel, there is a declaration of the auto capture threshold, whatever may be the threshold. After that, there is 0.25 addition to that threshold, and the pacemaker function shall start with a set AV delay, which it starts here. Although the first pacing spike itself captures the myocardium, which is very well seen in AVL, somehow the pacemaker feels that there is inadequate evoked response and possibly loss of capture. For the pacemaker, it is a loss of capture and gives a backup pulse after 80 to 100 milliseconds. So the same thing happens in the next beat also. The PR interval is longer here because another algorithm, which is the inherent part of auto capture algorithm, comes in play, which is called fusion avoidance algorithm. And that too, although it was an adequate capture, we can see on the ECG, for the pacemaker, I think there was no evoked or less evoked response, and it was also again annotated as a loss of capture and a backup pulse came. So I annotated them as backup pulse, which is unnecessary because it was actually inappropriate backup pulse which has come here. And because of this, the pacemaker again goes into auto capture threshold testing, and this starts this auto capture threshold search. The same thing or a similar thing happens in panel B. What we see here from the first 9 beats, there is auto capture threshold search going on with a very short AV delay. These 4 beats, these 4, 5, 6, 7, these beats had 2 pacing spikes. But if you see that the first pacing spike, which is a ventricular pacing spike, assumably, so it did not capture the myocardium. And then the backup pulse came. So these pacing spikes actually had a true loss of capture. This is during the auto capture threshold search. This is the part of the algorithm. So the backup pulse came in, which were appropriate. So those I have annotated them as a necessary backup pulse. So during this auto capture threshold search, in this 9th beat, there was a declaration that this is whatever it may be, this is the threshold. So after that, addition of 0.25 millivolt, the patient, the device starts a normal pacemaker functioning at a set AV delay. Unfortunately, in the very first beat, although there is a adequate myocardial capture for the pacemaker, there was a loss of capture and unnecessary backup pulse came in, and this thing keeps on going on, and it went on and on. When we check the device parameter, by that time the ECG actually had become normal already, and all parameters were actually normal along with the freeze capture, which is also normal. The threshold, impedance trend, everything was within normal limit. The auto capture threshold for this patient was 1 volt at 0.4 for the ventricular lead. So the final diagnosis for this patient was actually abnormal evoked response detection, leading to abnormal auto capture functioning, which kept on repeating the auto capture threshold testing. This highlights the fact that even though an initial point of time when the patient underwent a pacemaker implant, the evoked response sensitivity testing favored and recommended auto capture, during follow-up, some or same the patient might have an unfavorable evoked response to polarization signal ratio. So one of the clues to suspect this uncommon phenomena is to observe recurrent spontaneous auto capture threshold testing going on. The other clue could be backup pulse or unnecessary or inappropriate backup pulse coming despite a successful myocardial capture. Our index case had both these features. What we did for him was his threshold was stable at 1 volt, so we made it 2.5 volt at 0.4 pulse width, and we observed him for next 15 minutes. And in fact, he is coming for follow-up over last 6 months. There is no such ECG recorded on follow-up. This is the PCM ECG after the programming. So the most important question what comes in our mind, if this is erroneous, sometimes can become erroneous, can it be catastrophic? Fortunately, there is no risk of bradycardia because if the evoked response is not sensed, a high voltage backup pulse or stimulation is going to come anyway. Generally, the evoked response on follow-up can be underestimated. The reverse is somehow not reported till date. This more sensitive evoked response setting, in one of the large study by AutoCap investigators, they found that this more sensitive evoked response setting on follow-up was required almost in 1/5 of the patient after the hospital discharge with auto capture on. So the take-home message from my case is ECG is cornerstone of pacemaker assessment, and it can detect abnormal pacemaker function even when the device interrogation is absolutely normal. And it is advisable to do a evoked response measurement and auto capture sensitivity testing in yearly routine pacemaker follow-ups. Thank you so much. I'll be happy to answer if there is any question.
Thank you to the presenters. We have had a wonderful 2 case presentations today. And I'm coming back to the first case by Dr. Anindya Ghosh. So
Yes,
that
sir.
was very elegantly shown. You were, over magnet showing the overdrive pacing, and that time your sinus load picks up, and that's the same rate, and you get a ventricular sense beat. So the tracings were very convincing. Even the intracardiac tracings were very convincing when you put the magnet. My question to you was that normally when you put the magnet on, now this patient was programmed to a rate of 70, right?
Yes, sir.
And when you put the magnet on, the rate goes to?
Sir, depends on the battery status, sir.
Right.
In a DTD pacemaker Medtronic,
Right.
if it is a beginning of life status, it will go
Right.
to rate of 85, provided
Right.
the threshold margin test is not a feature of that device. In Advisor, there is no threshold margin test, sir.
Right. And what happens
otherwise-
what happens if there's a threshold margin test feature in the device?
Yes, sir. If there is threshold margin test, there will be 3 impulses delivered at a rate of 100 BPM. The
Right.
first 2 impulses will be at the programmed output. The third will be at a 20% reduced output.
Hello.
And provided if the battery status is such that it has reached ERI, it will first convert to
Hi,
VVI,
Shumpai. Dr. Ashish Nabar here from Mumbai.
and it will
Would
become
you like
the
to
rate will
join
become 65.
the session? Your
65
session
is
is
unique in
on.
sense it cannot
Would
be
you like to
programmed in a
join?
Medtronic pacemaker.
We could interact
Right,
further in
right.
that
So
case.
it will go to 65. So 65 means it's nearing almost like a ERI or RRT indication.
Yes.
And if it's 85, that means the patient is having almost like beginning of life. So there's
Yes.
still life left in the battery.
Yes.
And as you rightly said, the threshold margin test is a feature only in some of the devices.
Yes.
And there the threshold starts getting tested beyond the output. Now,
Yes.
regarding the pacing thing, I'm quite okay because the magnet rate showed that the rate had picked up to 85. You could document the PP pace rhythm
Yes.
with the spike and then following QRS being narrowing.
Yes.
The first tracing, the one which was with the 5th beat where there was a positive QRS, where it was said as the atrial sensed being conducted, atrial pace being conducted with a native QRS because of concealment by the previous PVC.
Yes.
Now, my query to you is, if we say that is a PVC, then how can the atrial pace be early? Because the lower rate which you had set was 70, which comes to a tachycardia cycle of length of almost 800 to 850 milliseconds.
Yes, sir.
So if we go with the explanation that this was the atrial pace beat,
Yes, sir.
which is coming earlier, so it is almost like 650, 700 milliseconds. Why should the device come faster than the setting which you set, lower rate setting?
Sir, I couldn't get the exact question, sir. After an A pace, why the second A pace comes earlier at a faster rate?
Correct.
Sir,
the one which is conducting with the narrow QRS, which is the V sense,
yes,
which is conducting with the V sense. If you see the P wave, if you say that there is a P wave which was there before and that's conducted down to the with a narrow ventricular QRS, which is V sense.
Yes, sir.
So if you measure that from the PP or the RR, now my question to you is it a A sensed algorithm or it's a V sense algorithm?
Sir,
in this device?
It is actually an A-paced event which is going down with a PR interval of near 700 to 800 milliseconds. So by that time, the lower rate has not expired, and it is actually V-sensed event. And because it is a V-sensed event, the device will think it's as a PVC. It will start a ventricular-atrial escape interval. It will not be an atrial-based timing cycle. It will convert for 1 beat to a ventricular-based timing cycle, sir.
Really? Now my query was that, like, if it's a V-sense event,
yes, sir.
Right now, the explanation provided by you was that the V-sense is because of the native QRS which is conducting from the A pace.
A pace, yes, sir.
Yeah. So if you say if it's A pace, that means if you calculate the PP interval, the pacing lower rate, it comes faster than the set rate which you've set, which is 70 beats per minute, which is 800 cycle length or 850 cycle length.
Yes,
so
sir.
that thing cannot be explained by your explanation of the sensed. So according to me, I felt there might be a possibility of probably a PVC, because if you see from that V sense, which you are seeing a PVC, and then you take the next QRS, that's a reset. There's a property.
Sir, can I open my
50 milliseconds.
presentation again, sir?
Actually, yeah, you can if you want. Yeah.
Yes,
but
sir.
we don't have access here because it's a video recording.
Sir, I'll show, sir.
Yeah, please show it. You can share screen if you want.
Yes, sir. Yes, sir. Just a second.
Yeah.
So can you see my screen, sir?
Yeah. Here, right? See, if you say that this one. So if you see the A pace rhythm, that is going at a rate of, this is without the battery, right? This is the native
this is without the
QRS
magnet.
without the battery. Now that is why you're seeing a rate of 70 atrial paced rhythm.
Right.
Exactly at 70, which is your lower rate rhythm.
Yes, sir.
So when you take the early beat, which is the V sense,
Yes, sir.
as the PVC or
Yes,
as the ventricular conducted
Sense
beat,
event. Yes, sir.
that means the A pace will be much earlier, or almost on the T wave.
Sir, this ventricular event has been a result of this paced complex, sir. So this A pace has been followed by a V paced at a programmed AV delay, but this P wave has gone down the AV node and resulted in this this QRS complex. There is no P wave in between, sir.
Yeah, so that would mean almost like a 1:2 conduction.
Right, sir. But this is not a conduction. This is like the pacemaker tracking not tracking, sir. It's a sequential AV pacing, DDD.
Right.
So A pace, V pace, and this A P wave only went down to the. I'll show you the ladder diagram, sir, which we proposed.
Yeah, but then see, if you have a one P wave with two QRSs.
Yes, sir. This P wave has a paced QRS.
Right.
And it also went down because there is a retrograde Venki back, sir. Because we have already seen during atrial pacing that antegrade Venki back happens at rates more than 100. And this is a rate of around 70. So there is 1:1 antegrade conduction every time, retrograde, antegrade concealed conduction in the AV node. But the retrograde conduction from the paced complex Venki backs, it gets blocked every fourth beat, thereby allowing the antegradely inscribed P wave to conduct down to the ventricle. That's why the shorter coupling interval, sir. That's what also we noticed during the magnet response. The first coupling, the first narrow QRS is at a shorter coupling interval. Then it becomes 85. So this is not a coincidental, sir. This is because this P wave has gone down to this QRS.
Okay. Chalika. Yeah, it's an interesting case. Thank you. So I think you can stop the presentation and I'll go to Deba.
I'll do it, sir. Yes.
Yeah.
Sorry, sir, if I missed
something. No, it's okay. Yeah. So Dr. Deba, it was an excellent case of evoked response potential. Yeah, my question was to you was that one of the doubts was raised was V pacing, right? Or rather a short AV, which you observed on ECG.
Yes.
Can you think of any other causes which can cause short AV? When you see ECG and something comes to like a short AV, right, in a pacemaker patient, when you think of a short AV, what would be the differentials which you would go through your mind?
So one is magnet can produce a little shortening, but if let's say it's a non-magnet ECG and we are considering a very short AV, maybe some means shorter than what we programmed. Let's say this patient was programmed at 150, and if I find something like, let's say 100 is the short AV you are talking about, sir.
Not necessarily short. My question is variable AV. So if you see keep changing AV, what would be like?
Okay.
Yeah, so not necessarily short, just a variable AV.
So one is it can happen near the upper tracking rate, something like a Wenke-Back phenomena, upper tracking rate. It can happen.
Correct.
Short AV, I'm not very sure anything else. Sometimes one thing can happen that if you have the rate responsive AV delay on, then even if you have programmed 150, let's say it can come to 100. But this was at 25 almost, so that was little unphysiological even for a program.
Right. So normally, if you see in the AV delays, there is a lot of discussion of variable AV delays. So variable AV delays, I think at least I can remember 3-4 causes. Okay, one of them is that when you have a sensed AV and paced AV, both are different. If you have a paced AV and sensed AV, then you have changing AV intervals. The second is search AV hysteresis, where you program AV hysteresis, AV keeps on changing and then
Yes.
getting prolonged. Even
Yes.
rate adaptive pacing. So rate adaptive
Yes.
pacing, as the rate increases, the AV delay keeps on changing. Like,
Yes.
so at least
that
I
is
can
what
think of these three. Of course,
Yes.
there is also ventricular pacing avoidance algorithms which can cause this, but they are not so common except in Bitronic, I guess, because now Medtronic is having this MVP,
Yes.
which is not necessarily like changing AV intervals.
Right.
And what would happen to your capture algorithm or evoke potential algorithm if you keep a magnet?
So if you put a magnet, what happens during the time when you put a magnet on a
Yes.
pacemaker, the auto capture algorithm for that time being, it will be stopped.
Yes, it will be
It
stopped.
will be paused rather.
Yes.
And what it will do, the last measured auto capture threshold, it will pace 1 volt higher.
Right,
So
right.
if it was, let's say 1.5 is the last measured threshold, it will pace for the time being, it will pace at 2.5, sir, at the set pulse amplitude.
Correct.
Hello.
Right, very nice. And just one last question, not a question, just for the sake of the fellows, just define what do you say by polarization signal and evoke potential? Because it's a very important concept. A lot of
Yes,
people
sir.
don't understand what is the polarization signal
Yes, sir.
when
So,
it comes to pacing.
One, what is evoked response? So auto capture algorithm functions based between the ratio of
We
these
always
two.
had some good
One is
descriptions about anatomy from Dr. Cabrera. And
Oh, you can go on.
okay. So so evoked response is when the lead paces at the ventricle or even atrium nowadays. Let's talk about ventricle. So when the lead paces, it stimulates the heart and it captures the local myocardium. So that gives back an impulse which is recognized at a evoked response by that lead. The other thing is polarization signal. That is, whenever a lead sends an impulse, there is a local electrons which will come near the pole. That does not depend whether you have captured the myocardium or not. So that is irrespective of your myocardial capture. So if you have a good evoked response by polarization signal or high evoked response by polarization signal, then the device recommends that you switch on auto capture. Otherwise, it will say it is not recommended. Still, you can switch on, but it will say not recommended.
Not recommended, yeah.
So
Correct.
the interesting thing which I found from this thing is that, let's say I have programmed this patient's auto capture on 2 years back. And then generally we do not test the auto capture evoked response ratio in the follow-up. So from now on, what I found that even the literature says that every year, at least once, you should check whether this ratio, which was earlier favorable, now it is favorable or not. So that we should test.
Okay.
Secondly, that although this led to a little confusion, but the patient was asymptomatic. Even the big literature, they says that there is no reported catastrophe for this, because every time on follow-up, they found that evoked response was underestimated. It was never overestimated for somewhat reason. That's why we are safe, but it will lead to drainage of battery because it will keep on checking the auto capture threshold testing, sir.
Thank you. Yeah. Thank you. So I think that both cases were wonderful. I had a good time listening to both of you. Like, thanks both again.
Thanks, seeing you.
Thanks. Bye bye.
Thank you, sir. Thank you so much.
I think we'll end the session here.
So we have a gap in it,